different hardware, and finally about CVT endovascular intervention. So this is a basic anatomy. We all know that these are the superficial venous system of brain. Includes a bigger one, the superior sagittal sinus, and then inferior sagittal sinus. Here we can see straight sinus, occipital sinus, and transverse sinus. This is the confluence of sinuses. Here we can see the sigmoid sinus. So the anatomical important points are the superior sagittal sinus. The straight sinus is like less than, for example, the straight sinus, and we compare to superior sagittal sinus, it is 1/3 in size, and it is usually 5 centimeter. The superior sagittal sinus is around 4 mm diameter anteriorly and 10 mm diameter posteriorly. The clot, when we see in the images, it is more in posterior part of the superior sagittal sinus, where technically, while injecting the thrombolytic agent for the endovascular procedures, it is important to understand the amount of clot so that we can decide about the dissolving agent, the quantity volume of the dissolving agent. And the superior straight sinus, the superior sagittal sinus usually drain into the straight sinus drains into confluence of the sinuses predominantly into the transverse sinus, that is left side, left transverse sinus. And the superior sagittal sinus, it is usually towards the right, and then right sigmoid and IJV. In 50% of cases, right and left transverse sinuses are asymmetric. This is common. About half of the people will have asymmetric sinus size. Right will be more than left. And in 20% of cases, there is a partial or total agenesis of transverse sinus, which we usually see in routine venograms. And in 10 to 15% of cases, the superior sagittal sinus drain into transverse sinus. And there is, in those cases, in around 10 to 15% of cases, there is no direct connection between left and right transverse sinuses. So with these entities, I will go ahead. This is the superficial cortical venous system. There is no much to discuss about this in terms of intervention. This Sylvian vein, vena flavi. Here we can see vena flavi, and superior convexity veins, and vena Trolat. Usually, these cortical veins drain outer 1 to 2 centimeters of the cortex and subcortical white matter. They have no walls. They exhibit reciprocal prominence. Means, if left side cortical vein is prominent, the right side will be smaller. That is reciprocal prominence. So coming to the deep venous system, there are different names for the areas which they get they drain. Medullary veins, subependymal vein, septal vein, anterior caudate, thalamostriate, internal cerebral, basal vena Rosenthal, vein of Galen. Vein of Galen is the great cerebral vein, which we know. And here the importance is this deep venous system drain predominantly from periventricular white matter, basal ganglia, and very important is thalamic region. And usually this deep venous system thrombosis is more grave, like CVT itself is a grave when it is a big one, but deep venous system will have a bit poor prognosis over the routine CVT. Coming to the indications of venography, there are different indications, which is in patients with venous hypertension, which is imaging negative. In that scenario, to look for any stenosis or occlusion, DSA we can consider. And in patients with unexplained tinnitus, same to look for any stenosis or occlusion in any one of the sinuses, and to know the collateral pathways in anticipation of surgical or endovascular occlusion of the dural venous sinuses, and to evaluate the access for the transvenous embolization procedures, and also for transarterial embolization of AV shunts, and venous catheterization may be done to monitor the pressure in this scenario, and to determine the degree of reduction of venous hypertension post-procedure. So basically, it is to know in patient with intracranial hypertension to look for any possibility of stenosis or occlusion in any of the sinuses or vessels in the venous system. That is the main indication where it stands for. And the venous accesses, coming to the venous access, the common one is femoral vein access. The procedure for the venous access is same: instilling the local anesthetic agent, identifying the vein. Then, if it is not, if we are not able to get the vein, then through Doppler guided venous location identification. Usually, this veins will have different sounds compared to arteries. The sounds of vein in Doppler will be like whistling through a tree. So usually we cannot see the spontaneous gush of blood like arterial. It will be a small it is like spontaneous subtle drops of blood with the dark blood. It is like venous blood. It is a venous blood. So venous access through the description is to get through access through micropuncture set 0.18 inch wire into the needle, and then coaxial dilator, then J-tip 0.38 inch wire under fluoroscopic visualization. We can see the J-tip wire at the right side of the spine. Usually, 6 French 25 centimeters long pinnacle sheath is useful in most of the cases. Larger sheaths are usually well tolerated in venous system because the wall can accommodate even bigger size sheaths. The other approach is internal jugular vein. It is usually recommended when ipsilateral dural venous sinus is identified in the image, and when we want to access in that area, it is recommended, but difficult compared to femoral venous access. The technique is to identify the carotid pulse, then inserting 22 gauge needle, cephalad angling, then connecting in a syringe, gently drawing blood to look for dark blood of venous system, then passing the 0.18 inch platinum tip wire carefully till the jugular vein, and then remove the needle, put the coaxial dilator, and go ahead with the insertion of the sheath. So the problem here is the support of underlying soft tissue is less compared to femoral approach, and the problem because of that the chances of buckling of wire is more, and because of which the potential like the access may at times we may miss the access. Then subclavian is it is easy to access as in terms of the venous access, but difficult to negotiate inside the venous system into the jugular veins. So it is very rarely used approach, and that is one reason. Because of the angulation, it is very difficult to negotiate the wires. And the other one is valves. Valves at times, because of one is angulation, and then presence of valves will make the procedure more difficult. So here we can see the rough anatomy of the atrium and inferior, superior vena cava and jugular veins. So here the wire will be hydrophilic steerable wire. Once we go to inferior vena cava, from there to right atrium, then curve the tip of the wire pointing laterally. When we want to go into the superior vena cava, we have to change the tip of the wire towards lateral. Then once we advance into the superior vena cava, then straight up for right IJV, or we have to make a right like sharp angle, then towards sharp angle towards the left side for left brachiocephalic vein, then to the left IJV. So this one point is important. This is because of the anatomical variation in access to the right IJV versus left IJV. Here, the problem with this is when we manipulate in the atrium, there are chances of arrhythmias. We have to be careful in that aspect. And usually, by withdrawing wire itself, we can stop the arrhythmic part. And the second one is the presence of valves. These are the bigger veins which will have valves. So to go through the valve, it is always ideal to use gold tip glide wire for the negotiation. So once we reach the jugular system, proximal to jugular system, that means above the jugular system, approach is through coaxial microcatheter or microwire assembly, 5 or 6 through 5 or 6 French guide catheter. So here the chances of buckling is more when we try to advance the microcatheter more distally. So to avoid that, stiffer catheter like North Star, Lumax, and these are the catheters which they have recommended. And the other is to change to incorporate a technique of tower of power technique. They mentioned it as a 90 centimeter sheath combined with a 100 centimeter guide catheter to create a stiffer platform so that we can avoid the buckling and we can pass the microwire easily. So stiff guide catheters give adequate support in difficult situations. So, and the other one is as veins are tortuous and they need a steerable soft tip wire to get the target vessel. So while negotiating through this system, always it is better to inject under fluoroscopic guidance or make a roadmaps like routine arterial procedures. The chances of emboli, especially air emboli, are more in the venous procedures because of the low pressure system, unlike the arterial. So always better to have double flushing and then continuous saline infusion, which is invariably considered in all endovascular procedures. Coming to the hardware, the wires, access wires are angle glide wire or gold tip guide wire, and microcatheter microwires I'll be discussing. Is the angle glide wire. The advantage is it is soft, flexible, and steerable. This gold tip glide wire, which is there on right side of the screen, the tip of the wire will have around 1 mm gold band. This will be very well visible under the fluoro, and we can easily navigate when it comes in the when we approaches a valve in the great veins. We can see under fluoroscope and easily pass through that valves. And microcatheter for vessel selection, it is transient or synchro, that is 1 for inch. These are the micro. The first image is microcatheter transient. Here the tip is 2 centimeter tapered ribbon core wire tip. The tip we can adjust the shape. We can shape and reshape while going into target vessels, and because of the flat tip, the torque will be high. Like we can easily rotate and make a good torque while negotiating through the vessels. This is the synchro wire. We can see the difference between a regular guide wire versus this synchro wire. Here also, this has a flat ribbon distal core, which enhances the shape retention and and give adequate torque while negotiating. For passing through the thrombus, J-tip headliner is advantage. It has advantage of less likely to go into small branches and cause perforation. So on to J-tip headliner is one which is better in scenario where we need to pass through the thrombus. Here we can see caudal to the inferior petrosal sinus or jugular bulb, we can go with 4 or 5 French Bernstein curve soft. We can see the angle glide catheter and Bernstein catheter. And for the coaxial approaches, 5 or 6 French angle tip and void. And microcatheter here is rapid transit, which is having large internal lumen. It is easy for the passage of the passage. And anatomically, superior sagittal sinus, to reach the superior sagittal sinus in adults, we should have a microcatheter which is around 170 centimeters. And the microwire must be around 200 centimeters in adults to reach superior sagittal sinus. The recommended microwires are J-tip headliner and soft-tip transcend microwires. And to get adequate good opacification, the DAC catheters, which we usually use in arterial procedures, they will give adequate opacification when we inject the contrast in arterial system. So while doing venous procedures, it is always recommended to have a arterial access also, because the venous flow is always towards the heart. So when we give contrast, the contrast will move towards the heart. So we may not be able to see what we intended to see. So always it is better to have an arterial access, inject the contrast, then wait till the venous flow, and we can estimate the amount of clot, and then we can further plan the negotiation of the hardware. So the technique which I have already told. So here we have to consider injections around 1 to 2 ml of contrast for the test, and the means less amount of contrast, and hand injections are more preferable because of the smaller venous, smaller wall support in the venous system. And for the large sinuses, recommended volume is 3 to 5 ml per injection, and if needed, depending on the size of the sinus, we can increase in the quantity of the contrast while injection. Routine known complications are non-neurological, that is anaphylactic reactions and hematoma at puncture site, but it is less frequent compared to arterial punctures. Rare but significant is DVT and pulmonary embolism. So this needs to be properly addressed in all procedures, especially in venous procedures. And neurological complications, these are very rare. One is a venous infarction and hemorrhage, but the possibility of neurological complications because of the procedure is very, very rare. So the important points in the reviewing images, where sometimes we may consider this as abnormal, as in like pitfalls, the unopacified blood from the tributary veins, because when we inject the contrast, sometimes the blood in the tributaries may come into the sinus, and it creates a filling defect kind of appearance in the system that has to be taken care of while interpreting the image. And the true filling defects or stenosis are static. So that true filling defects, we can, while changing the frame to frame, we can clearly demarcate compared to the false filling defects of unopacified blood from the tributary veins. Then repeating the run may help confirm the presence of real defect. Once we do injection, keep the image like 2-3 frames, we can identify the real defect. It is a regular practice which we do. And then another important anatomical aspect is that Pacchionian granulations. These are normal granulations in the venous system, which usually located at lateral aspect of transverse sinus, and these are This seems to be filling defect, but not in real. These are the anatomical points. So coming to the CVT, endovascular interventions of CVT, there are so many indications as per the book, but the patient selection is important while considering for endovascular intervention in CVT. The routine case series or case studies which put out the point about considering patient with for endovascular intervention. The patient population is the one with the one who is on adequate amount of medical management, despite of which who is getting recurrent seizures, coma, or disturbed consciousness, deep cerebral vein thrombosis, as I told earlier, and then possessive fossa involvement or progressive focal deficits, and patient who is not able to receive anticoagulation, maybe because of a recent major surgery. In these kind of scenarios, these are the ideal candidates who are intended for the endovascular intervention. The techniques for intervention are penumbra reperfusion system, and then thrombolysis either by urokinase or alteplase, and then balloon assisted thrombolysis, rheolytic catheters. Here vascular access, as I told previously, either femoral vein or internal jugular vein. Always better to have arterial access, and then access wires are angle glide wire or headliner gold tip glide wire, that depending on the need. When we wanted to go through the valves, then it is always better to have gold tip glide wire. To reach the target vessel, better to have soft tip transient and synchro wires. So guide catheters, as I told previously, always better to have a large lumen glide catheter to consider multimodal therapeutic approach. For example, once we go for a procedure, it may be like thrombolysis and then balloon assisted thrombolysis and then thrombectomy. Like we can we can mix two modalities together. For that, we need to have adequate room for the hardware to incorporate in the sheath. So most of the times 90 centimeter sheaths works well. And microcatheter, as I told previously, it is rapid transit microcatheter for intracranial venous catheterization. To reach superior sagittal sinus, there should be a 1 centimeter, 170 centimeter length microcatheter. And the balloons for the venous thrombolysis or thrombectomy, balloon must be sized smaller than the vessel which is being treated. And we have to start with 2 to 3 mm diameter balloon. This is like a regular arterial approach only. Best balloons are over the wire, low compliant angioplasty balloons with an internal lumen through which thrombolytic agents also can be infused. The shaft of the balloon catheter must be generally 150 centimeter to reach the target vessel. NC Ranger and NC Raptor are the wires which are usually studied, usually considered in previous case series also. Soft flexible balloons, the problem with soft flexible balloons is difficulty in going through the thrombus. So it might be, at times it is difficult for the soft flexible balloons. Thrombectomy catheters, penumbra reperfusion catheters, and then angiojet catheter. Here, I just wanted to show one case scenario, following which I'll just show a video from which I have taken from internet. This is not our case, but to have an idea about the endovascular approach, I have taken that. This is a case of a 30-year-old female who is on OCP, presented with severe headache, acute onset. Here we can see the this contrast image, non-opacification of the sagittal sinus. This is the angio of that patient. Here after arterial phase, we are not able to see the venous filling in the posterior. Here also after arterial, there is no contrast going into the venous, either sagittal or transverse, because of the big size of the clot. And vertebral injection also. So this is the video of penumbra reperfusion system. Here they pass the hardware, and they are here we can see they are taking out the thrombus through the penumbra system. And for the thrombolysis, as I mentioned, either urokinase or routine alteplase. For alteplase, 1 mg in 1 ml dilution, at the rate 1 ml per minute. Maximum dose is 0.9 mg per kg, like for arterial ischemic strokes. But we should not reach more than 40 mg in total. And we can connect this to the while injecting the thrombolytic agent, gentle pushes by microcatheter create crevices in the thrombus, so that it will be easy for the thrombolytic agents to percolate in the clot. So the success rate of thrombolysis will be high. Here, once we inject the thrombolytic agent, it will take hours to see the results. The idea is to inject as much amount of thrombolytic agents as possible within the clot, so that the recanalization will take over time, and then the success may be seen in next subsequent 6 to 8 hours image. So, as I mentioned previously, the JTAP headliner is the one which is useful hardware to go through the thrombus. Here. This is one video about balloon assisted thrombolysis. Here in this video, what they did is they passed
balloon is in the process in which we use a large 6 to 8 millimeter balloon.
Is it visible?
Back across the sinus.
Yes, yes.
Okay, thank you, sir. So they passed the balloon and then they inflated it. After the instilling thrombolytic agents, this is the process. They pass the balloon, they slowly pull the balloon after inflation, so that the clot can, they have removed the clot with this gentle drawing of the balloon. Other technique is using rheolytic catheters. The advantage of this rheolytic catheters is they can physically remove clot and quickly restore the flow with a decreased risk of embolization. And when it is best when mixed with the other modality, that thrombolytic therapy. Here we can see how this works. This angiojet device, which has side ports for the thrombolytic agent to for us to inject the thrombolytic agent. Here they are going into the thrombus, injecting the thrombolytic agent and evenly, and wait for a while. Then again pass the catheter and then slowly apply the suction. For applying this suction, there must be a mechanism. It is a separate suction pump which is required for this kind of angiojet system. So these are the techniques for the endovascular approaches for cortical venous thrombosis, cerebral venous thrombosis. So the venous procedures are rare, but life-saving, especially when we consider it for CVT patients. Patient selection is very much important, and it is purely case-based. Always the success of multimodality approach for CVT is high. That is well reflected in different case series which were published previously. And prior idea of approach and hardware selection is very important for venous procedures. Hello?
Yes, you're audible. Yeah.
Sir, I'm done with presentation, sir.
Okay.
So the case selection in patients with CVT is very much important. Though patient come in GCS of 3, that doesn't mean that it is out of hands. We can give a try, but we have to have clear idea about the patient, and then we can go ahead, especially in patients with venous system thrombosis.
So, Gigi sir, your comments?
Hello.
Hello.
Sir, good evening.
Yes,
sir.
Yes.
Yeah, it's a very life-saving procedure. We have done probably around 6 or 7 cases, not more than that. One was a very interesting case now after vaccine, the VIT, the vaccine-induced thrombotic thrombocytopenia. That patient actually did very well. He required decompression also, and the second point to remember is you don't need to achieve a full recanalization. That the whole thrombus need not be taken out. Even a little bit of recanalization is enough.
Recanalization, yes, sir.
So there is no, don't think that the whole sinus has to be completely cleaned up and all that. Just by, even if nothing is possible, just by taking the diagnostic catheter or the aspiration catheter right from the front towards the back couple of times, macerating the clot might be more than enough. So usually they make it recanalizes on its own with the anticoagulation to be continued. KEM hospital has got a very good, excellent series on intra-sinus thrombolysis, where they put a microcatheter in the anterior superior sagittal sinus and then leave it there with a continuous infusion of thrombolytic agent. They use, I think, initially urokinase for 24 hours and then again do a check angio and see. And that has been found to be very useful in their series. But with the advent of newer aspiration devices, especially large bore aspiration catheters, the stent retrievers, the preferred choice is now thrombectomy. But the problem is the awareness of the thrombectomy and the benefit, venous sinus thrombectomy, is very low among general neurologists. So many times the patients are not referred. That is the problem.
Yes, sir. I completely agree with sir. Actually, we had like 2-3 years. We do hardly 1 or 2 procedures a year, not very much. So I had 3 years ago, I had one girl, a 16-year-old girl, who had fully dilated people with a full bilateral cerebral edema, bithalamic hemorrhagic infarct with venous sinus thrombus, predominantly in the posterior sagittal and basal vein, in the basal vein and the straight sinus. Just because neurosurgeon denied to decompress, and the only daughter, I just as a last option, I've taken this urokinase with actually 6 French RC guide, because we did not spend much because the prognosis may be bad. But to my surprise, it was not a full recanalization, only partial recanalization. I have aspirated from the side, from the superior sinus as well as from the straight sinus. There was some opening, some circulation was there, but by next day, actually, the CT scan swelling has come down, pupil started reacting, and actually that patient has gradually improved, and she is now walking with a little bit of spastic gait on one side. So that's very surprising. So I think, opening some channels will promote blood flow, and really it's maybe sometimes very, very life-saving, unexpectedly life-saving. I think like hardware we can use as per, because there is some relaxation, because we can use some catheter, because spasm will be less. We can use some good catheters. sometimes coronary if the cost is a big issue. And I think we have Cat6 and all will be very useful definitely for aspiration. And stent retrievers may be a costly affair. I've seen people using stent retrievers, but I think we would try to reduce the cost, and maybe we can use it for arterial strokes.
For the beginners, it is one of the easiest procedure to do, because one, you don't have to bother about creating a complication, because any complication is very, very unlikely. And initially, because it is a rarely done, the femoral venous puncture is easy. Just go medially and puncture, and you get a venous puncture. The only problem is in the neck, where negotiating the valve might be a bit difficult, but if you play around a bit, it can be easily negotiated. But much more easier now is to, under ultrasound guidance, you can directly puncture the IJV and go up from the neck if the patient is comfortable. Second is, initial days when I was very extremely unhappy, because you do aspiration couple of times. Angiographically, it doesn't look very good. It will not be, because you can't show it to someone. No, it has not completely recanalized. Still there is occlusion here and there. The clot does not come out completely. So it doesn't look very clean at the end of the procedure. So I was not very happy with whether I am taking out. A lot of clot comes out, but the sinuses may not be completely cleaned up. But no, don't worry. You just do it a couple of times. At least take the catheter up and down a couple of times. That is more than enough. There will be a significant improvement in the next 24 to 48 hours. And it is one of the easiest and safest procedure to do. Only thing is that it is not done routinely, so your exposure may be very limited. So you can easily play around with the wires. Nothing will happen. It's not like an arterial system, venous system. Bobby?
Yeah, I think Uday Lime sir has got a big series, like something like.
Yeah, Uday Lime, they have what they used to do was, they used to take a microcatheter into the anterior superior sagittal sinus, leave it there for 24 hours on continuous infusion, femoral line itself, and plaster the microcatheter onto the femoral thigh. They will secure this thing there and put them on a continuous infusion. Because it's you can just connect it to a pressure pump, not a routine pump itself, because it's a venous site. Pressure is low, and leave it there for 24 hours, a slow infusion. And next day you take an angiogram, the whole sinus would have recanalized beautifully. They actually did a lot of publications on sinus thrombolysis. But I don't know. I mean, Vivek, have you done with TPA or tenecteplase? I have not done.
I have done with the urokinase many cases, like not too much, but like 5 to 6 cases. The urokinase will give excellent results. And actually, I was, because of the backup is less in the ward and all, like I did not keep this catheters inside like Uday Lime sir, but I think if we patiently wait 1 to 2 hours, we can go on infusing. There will be definitely an outcome. I mean, I think
some for 12 hours, then take up for a repeat check angio, and if required, I think they for 24 hours like that.
That will be very good actually. 12 hours, that opening is also sufficient. Some opening will be very useful for venous.
Yeah, that thrombosis. Is initially I used to be very depressed, because angiographically you can't show it to anyone. The sinus has not completely opened and all that. But the patient makes a very good improvement. Later only I realized the fact that you don't have to have a very good clinical, radiological improvement. Just opening the sinus is more than enough. Anything else? The idea should be like we should talk to the give talks to the general neurologist as much as possible, and then see that patients are referred for thrombectomy. Okay.
Okay, sir.
Can you send the presentation to the group?
Yes, Jafar, you can make a PDF.
Yes. Yes.
So I joined a bit late. Now, did you add the papers from KEM?
No, sir. No.
So what you can do is just go through the literature and whatever publication is there from KEM, just go through that. And if there is some protocol to be followed, please copy that and add to your presentation.
Okay, sir.
Because there should be some protocol, and there is a protocol onto that. Now, how much to give, how long to give, and what is the procedure and all that.
Okay, sir.
So the advantage of going through these articles is that you can exactly go through how the technique used, what was the catheter used, how did they do, and all that. That is the thing you should look into, and how much urokinase was used, how much it was continued, and all that. As Vivek was pointing out, using a stent retriever becomes a very, costly exercise. Whereas the advantage of using a microcatheter is you can use a Aux microcatheter. If the patient is very poor, it's zero cost. It's like an angiogram only. Just take any guide catheter into the IJB and take a microcatheter into the anterior superior soil sinus, start an infusion. The cost is zero. Zero means it's like an angiogram only. And you can always use an Aux old aspiration catheter. Okay, good night.
Okay.
Vivek,
okay,
you want to add
you.
something?
No, I think we have mentioned hardware and dosage and all. He has mentioned in one slide, but I do not know what was exactly. Remember that KEM protocol. We can add those things into the slide set, and he will make a PDF and share to the group.
Yeah,
Yes,
whatever additional things that you can add to that. No, add to that.
Okay.
Add to the presentation and share it. Thank you.
Thank you.
Okay, Jafar. Good presentation. Thank you.